Good morning to everyone. I am Ann Dunlop, a family and preventive medicine physician who is engaged with the Global Collaborating Center in Reproductive Health since coming to Emory University as an intern in 1997 after meeting Dr. Brand in both nursery and research rotations. I'm pleased to have a few minutes with you to share my involvement with the center in translating public health and clinical data into practice and policy change in Georgia by way of a focus on implementation science. First of all, let's touch on implementation science and what it is. It is the study of methods to promote the systematic uptake of research findings and evidence-based practices into the clinical care of patients and populations. It focuses on understanding and addressing the barriers and facilitators to uptake of these evidence-based practices in real-world settings. The ultimate goal of implementation science is not simply to generate knowledge, but rather to improve healthcare and public health quality and effectiveness, and to do this by achieving improved reach, uptake, adherence, and follow-through of the evidence-based care, again in real-world settings, in order to achieve impact at the population level. For context, it's important to note that implementation science is part of a continuum that ends with the question of what makes a program work in practice settings, and which proceeds from a line of research questions that answer, does the program work, and could a program work? The foundational basis of implementation science is evidence-based interventions. These are the practices, procedures, and programs that have been proven to be effective based on peer-reviewed empirical evidence. There are many sources of evidence-based interventions, and these are warehoused in many curated websites that are freely available. There is always also lots of room for creating new evidence-based interventions based on local context, and we have spent a great deal of time doing that in Georgia. It is important to note that there is a whole science around implementation strategies, or the means for integrating and sustaining evidence-based interventions in the real-world setting. These are specifically the how-to components of change. We are not going to go into these today, but I just wanted to convey that this is a well-studied area and well-recognized area of need to achieve sustained change in practice in real-world settings. But this is perhaps the most difficult stage of research to fund, as traditionally funders focus on generating the data to designate an evidence-based practice, but not necessarily the additional work that is needed to move the evidence-based practice into daily clinical practice and public health policy for becoming the standard of care. In terms of conducting implementation science, the first step is in identifying the evidence-based intervention appropriate to your local context. The second step is adapting and piloting the policy or intervention to better suit the local need. The third is evaluating the implementation in a specific setting, and the final is the larger scale-up of an intervention or policy. I believe through the center, we have done a great deal of work on steps 1 and 3, and we are truly striving to more fully fulfill step 4 through our work. I'll start out with my talk today by describing some data analysis work that was undertaken by the Collaborating Center, which was a first step in elucidating the need for evidence-based practices around improving underlying women's health status as a strategy for both improving maternal health and infant mortality in Georgia. So we undertook this study with our partners at the Georgia Department of Public Health, first asking these questions. First, since 1981-83, does excess fetal infant mortality persist in Georgia? And second, if so, which intervention strategies would result in the largest reduction in Georgia's current total and excess fetal infant mortality? For this analysis, we used vital records and expertise, as I said, from the state of Georgia Department of Public Health. Vital records spanning, first we used 1981 to 83, then 2001, 2003, and then we later updated this with data from 2013 through 2018. For purposes of today, and I cannot go into the full background of the analysis we did, but suffice it to say that we worked together to categorize infant deaths in Georgia using a system developed by Dr. Brian McCarthy when he was at CDC that is based on information in the birth certificate and fetal or infant death certificate along two axes. First, the age at infant death, categorized as either a fetal death, an early or late neonatal death, or a postneonatal death, and infant birth weight, categorized as normal weight or above, low birth weight, or very low birth weight. For each colored block of cells, which I will explain momentarily, we calculate a birth weight proportionate mortality, which reflects the contribution of that colored cell category to the overall fetal infant mortality rate for a specific geography. We used this model because every cell in that table can be linked in an evidence-based way based on prior research conducted by Brian McCarthy and others at CDC. Each of those cells can be linked to an impactful intervention proven to affect deaths in that cell or block of cells. So the color coding reflects these interventions. So deaths, fetal infant deaths occurring to very low birth weight infants, for example, that's the entire blue block of cells regardless of age at death, can be best addressed through strategies that improve women's and maternal health, including family planning, nutrition interventions, micronutrients, attention to sexually transmitted infections, substance use, anticipatory guidance, management of chronic conditions, preconception care, and pregnancy early identification and linkage with care. Deaths in the red box can best be intervened upon through maternal and fetal care interventions. Deaths in the green box through newborn care interventions, and in the pink box through infant care and supervision interventions. Using this approach, we honed in on what's called the opportunity gap, or the potential for reduction in excess fetal infant mortality based on comparison of one subpopulation with the subpopulation in the state that is experiencing the lowest rate of fetal infant mortality, regarding that lowest rate as that which should be able to be achieved by other subpopulations with appropriate intervention. This opportunity gap analysis revealed that while there was a considerable reduction in Georgia's fetal infant mortality from 1981-83 through 2001-2003 and continuing on for 2013 through 2018, substantial excess fetal infant mortality persists, especially for Black infants. And the largest proportion of Georgia's excess fetal infant mortality is attributable to poor underlying women's health status and issues related to maternal care. And racial disparities in these women's and maternal health issues are the principal drivers of racial disparities in infant survival. Thus, strategies that would improve the health of women prior to and between pregnancies hold the most promise for achieving further reduction in Georgia's fetal infant mortality and closing racial gaps in these outcomes. This analysis triggered our group, together with the Georgia Department of Public Health, to examine trends and racial disparities in very low birth weight births in Georgia. This analysis revealed that differences in rates of very low birth weight delivery, which are attributable to poor underlying women's health status, which we just showed, and especially recurrent or the recurrence of a very low birth weight delivery, are major drivers of the racial disparity of fetal infant mortality in Georgia. So taken together, these two data analyses were the building blocks for our formulation of an intervention package to begin to address the issue of recurrent poor pregnancy outcomes, especially for Black women in Georgia. And this brought about the Grady Inter-Pregnancy Care Program. We used a review of the literature to define an inter-pregnancy care package to address 7 areas epidemiologically linked to the low birth weight and preterm delivery, including reproductive planning or assistance in achieving intended and well-spaced pregnancies, prevention, screening, and treatment for sexually transmitted infections, micronutrient supplementation and attention to nutritional deficiencies, screening, prevention, and treatment for periodontal disease, management of chronic health conditions, and treatment and referral for substance use and abuse, and screening and treatment for depression, psychosocial stressors, and domestic violence. We provided this intervention as a package of primary care in an individually tailored way in which women were supported with an inter-pregnancy care plan that was individualized to them and a trained resource mother providing community outreach for 24 months. Evaluation of the Grady Inter-Pregnancy Care Plan showed that the provision of this inter-pregnancy package improved the health status of enrolled women. Those enrolled in the program were substantially more likely to achieve desirable and optimal inter-pregnancy intervals, and they experienced significantly fewer pregnancies with fewer adverse pregnancy outcomes compared to a historical control cohort. Dr. Brand and my involvement in this program at Grady and the literature review that we undertook to inform the Grady Inter-Pregnancy Care Program resulted in our invitation to be part of the Center for Disease Control's Select Panel on Preconception Care, which was charged with defining the components of preconception and interconception care. The panel then produced a set of recommendations in two forms: an overriding set of recommendations for preconception health and health care that was issued as a morbidity and mortality weekly report, and a set of distinct clinical guidelines and recommendations in the form of a special preconception supplement. A major recommendation from the national work was that as part of primary care, we should provide risk assessment and counseling to all women of reproductive age to reduce risk to pregnancy outcomes. A recognized gap was that few primary care providers provide preconception care services or interconception care and had no tools to do so. So a recommended action step was a charge to develop and evaluate practice screening tools specific for the primary care setting. In seeing that call, our group pulled together a group of clinicians, including obstetrician gynecologists, family physicians, internists, nurse practitioners, and nurse midwives, to assemble the varied set of screening, health promotion, and intervention strategies for which there was evidence, and we packaged that into a preconception toolkit for Georgia. And the Georgia Department of Public Health supported us in this work and began to implement this toolkit in their family planning and women's health clinics. At this point, I wanted to pause to point out really where we are in the continuum of clinical research with another look at that continuum of implementation science. At this point, based on systematic and other reviews and some established feasibility studies, including the Grady Inter-Pregnancy Care Project, we had come to the point where we had done some effectiveness research around particular parts of preconception care, but not the whole package. So we undertook a plan of implementation science to understand how to introduce this evidence package into primary care. This implementation science work started with, as a first step, integrating the reproductive planning component of the preconception toolkit into primary healthcare to explore the acceptability and perceived utility of doing this with both women and men as recommended in the guidelines. For this implementation work, we engaged with Emory and Grady primary care clinics to administer the screening assessments from the preconception toolkit as part of routine healthcare encounters, and we administered semi-structured interviews to understand patient perceptions. We found that for female patients, they viewed this positively by nearly all of them, approximately 97%, and important by the majority, about 80%, regardless of their childbearing intentions. For male patients, the majority viewed it positively, about 72%, and as important according to their childbearing intentions as well. Based on that initial success and show of acceptability in these primary care clinics, a next step was to implement the full preconception care package into primary care clinics to conduct a practice and patient level outcome evaluation. We again identified partners at several primary care clinics. I'm not able to fully share the results with you today due to limited time, but we definitely saw health benefits among those who partook in the intervention in terms of decreased risk of unintended pregnancy and short pregnancy intervals, improvements in knowledge and recognition of one's own reproductive health risks, including uncontrolled and poorly managed chronic health conditions. Considering our knowledge that many women who need primary care do not actually get it because of lack of health insurance coverage and simply lack of knowledge and awareness of the importance of primary health care, we also sought to test elements of the preconception toolkit in WIC clinics, where many postpartum women and women with small children under 5 years of age visit regularly to obtain their WIC foods and food coupons. In this setting, we found that reproductive health risks were prevalent among those women coming to the clinics, the WIC clinics, to receive their food coupons. And importantly, the vast majority of WIC clients and staff found that the preconception assessment and counseling during the WIC encounter was acceptable and important to them. In addition to evaluating the toolkit in the WIC setting, we also assessed its acceptability and effectiveness in the neonatal intensive care unit, or NICU, with the rationale being that mothers with an infant in the NICU are known to have underlying health issues that contributed to the adverse birth outcome. And this same set of women are less likely to attend or even be able to attend their postpartum and own healthcare appointments as they focus on the care of their infant and family. Yet the care of these women is vitally important for the woman's own health to avoid maternal morbidity and mortality, and for the timing and outcome of any subsequently conceived pregnancy. So we repackaged the toolkit as calling it the Strong Healthy Moms curriculum for delivery in the NICU setting. We found that those in the intervention group were more likely to attend postpartum care, to adhere to their medications, and correctly and consistently use a method of contraception. Importantly, these mothers and the NICU staff viewed receipt of the screening, counseling, and referral services through the NICU in a very positive light. Perhaps the most impactful expansion and adaptation of our early work with the Grady Interpregnancy Care Program has been Georgia's 1115 Medicaid demonstration project known as Planning for Healthy Babies, which had 3 objectives. First, to reduce Georgia's low birth weight and very low birth weight delivery rates. Second, to reduce the number of unintended pregnancies in Georgia. And third, to reduce Georgia's Medicaid costs by reducing the number of unintended pregnancies by women who would otherwise be eligible for Medicaid pregnancy-related services. A very unique aspect of Georgia's Planning for Healthy Babies program, the only one in the nation in fact, is an interpregnancy care provision program based on the Grady program that expands coverage under Medicaid for up to 24 months post-delivery for women who deliver a very low birth weight infant. This interpregnancy care package through Medicaid includes primary care and family planning services, as well as the attention of a resource mother for the 24 months of coverage. Findings to date from the interpregnancy care program show that women enrolled in the state's interpregnancy program and using family planning services are less likely to have clinically inappropriate interpregnancy intervals that put their own health at risk, as well as the risk for subsequent pregnancy. They are less likely to have a repeat delivery within 18 months of the index very low birth weight delivery. And those who do have a repeat delivery are significantly less likely to have that pregnancy end in another adverse outcome. While we have shown today some promising approaches with programming and policy in Georgia, there is still much room for improvement in Georgia. Georgia ranks 50th in maternal mortality, 46th in infant mortality, 45th in terms of low birth weight rate, and 48th in the percentage of women aged 18 to 44 years who remain uninsured. While we do have some promising models, toolkits, and policies at our disposal, clearly we need implementation science approaches to oversee their dissemination and integration into routine care and practice, particularly in those locations for which we are most likely to reach women and patients most in need of these services. Thank you.